Hey, welcome again. We have a new season of Revolution from Your Bed, and I'm so excited because today I have a friend and a colleague that is a fellow Viennese. I'm not really Viennese, but I'm a guest here in Vienna. Dr. Margret Jaeger. Um, she has a very unique profession, and this profession is something that I believe that is the perfect training to be the solution for a lot of those problems we face in healthcare. And this profession is called medical anthropology. I'm sure that half of you never heard about it before. Maybe you heard about anthropology, you heard the word medical, you probably don't know what's the connection between them. And welcome, Margaret, and let's see what we can learn about this amazing profession today.
Thank you, Roi, for this lovely introduction and for the invitation today. That's already an advertisement for anthropology and especially for medical anthropology. So it's a pleasure to be here to talk to you.
It's a pleasure that you're here. I'll ask you the question to start up the conversation. What is medical anthropology?
Yeah, so let's start. The discipline of anthropology is the science of men embracing women. Somebody important said this once. I love this definition because anthropology is really everything which is important to us human beings from birth to death, and everything in our lives, from how people are born, how we live, how we work together, which tools we invent, how we relate with nature, animals, people, everything in our lives. And medical anthropology is just one subsection of it, and it deals with health and sickness and everything you can imagine that is around what makes you a person and what involves issues about health. And of course, this is on different levels. This can be on the very individual level, like how you feel today, how you experience the health system in the region you live in, but it's also how a group of people behave, or how a whole society behaves, or how a whole public health system works. Because if one thing is certain, we can say medicine has culture. This is not from me, this is from Cecile Hellmann, a researcher a long time ago. But there is no objectivity in medicine. Medicine is practiced, even medical knowledge is different depending on the region. So it's also about the place and the time, actually, when we're living in. So I have a huge passion for medical anthropology, and because you can go in every direction you can imagine, from people's birth till people's death. There is everything in it.
And beyond, even I've seen some articles that are talking about like the costumes of death and burial, and this is really exciting. And I will ask stupid questions, and I will pretend I don't know about this subject. This subject is so interesting to me that I'm actually considering doing a PhD in it. So I want to ask, what's the difference between sociology and anthropology?
Yeah, so if you ask me what is the very specific thing of an anthropologist is, I see you holistically. So I always have a person in front of me whom I'm probably talking to, but I want to know the person's story, the person's family story, to knowing the social determinants of the person. So the sociology looks at one topic very specifically and is not that holistic. And of course, there is quantitative sociology and there's qualitative, also doing interviews. But the very specific thing of anthropology is conceptualizing things holistically and getting always the big picture and then narrowing it down and up again. So this is how I explain it, and how you what you also can you perceive when you read sociological texts and when you read anthropological texts.
Oh, thank you. That's super interesting. Like the first thing that's coming to my mind is what would happen if a medical anthropologist would be the Minister of Health, for example.
Oh, that would be I never knew one, but actually a Brazilian president was once, when he was president, he was married to his wife, who was an anthropologist, and therefore whole Brazil got known more about anthropology.
So, wow,
this was in the 90s. So I would love a medical anthropologist. That's
No,
really
because
sad.
it's so holistic. I wish there was a course in university that in medical school or in health profession school that you learn about this holistic approach, because as someone who knows a bit about medical training, it's very not holistic. Am I
Yeah.
right?
Yeah, in many schools not. So gladly, since the 1960s, medical anthropology exists in American medical schools, and it's also part of this main medical exam they have. In many other countries on this planet, also in Austrian medical schools, in some of them, medical anthropology is present. But what you don't have really is, I think, medicine. The study of medicine and training doctors lost the holistic approach when they moved to the organ-based approach.
Yeah.
So if you find an old trained general practitioner, mainly he in Austria, because there were mainly men, they have this holistic view and they are able to think holistically, and they are better in diagnostics, and therefore they are probably also better in offering therapy. But since we have switched to organ-based curricula, the holistic thing got lost, and it's very hard to get it back in the curriculum. There are very few medical schools, for example, in Germany. There is one in Brandenburg. There, the medical faculty is led by an anthropologist. You know? She is absolutely cool. And there is also some private medical school in Germany, which is also more based on anthroposophy, and they have a different approach. But the very general, traditional school medicine approach, biomedical approach, lost the holistic approach, and it's hard to get back.
So if I'm not kind of coming from a research stand, if I'm just coming from the patient view, I've met doctors from all around the world, and there is the type of doctors that are the expert clinician, but not in the sense of cold clinical sense, but in the sense of we didn't have the tools we have today. We had training that is more holistic and more, let's say, I will call it social based, that you look at the in German Einstellung, or like the system or the setting of the family. And my pediatrician, which I write a lot about in my first book, Revolution from My Bed, was like this. She was trained in the 50s, and she touched, she felt, she knew, and she knew to ask the right questions. And it's just amazing to me that instead of preserving this kind of training that led to amazing doctors, and I must say that I really met doctors from the US that are in their 60s, 70s right now, that are just real clinicians in the sense of the ability to by themselves diagnose things by getting all the inputs. And today what I think we've become is that we have expert medicine, and even the little doubt that a GP have, they refer you immediately to an expert, and the expert is an organ expert. And in my own story, it was interesting because every different expert try to diagnose a different illness in their field. So the lung doctor thought I have a lung disease, and the gut doctor thought I had a gut disease, but nobody ever talked to each other and thought about the nervous system together. They're all connected. So that's an interesting view. So I want to kind of challenge you here. We were in some places in the world in a place which we train in a more holistic way. Medical professions. I don't know if it was for nurses or for other professions, but I'll assume that yes, because the way I perceive medicine. Why do you think that currently there is no room in the curriculum for more holistic approach?
So let me start with Rudolf Virchow, the big German medical doctor, who once said medicine is a social science. Because people feel sick because of many things, you know. And the Virchow was aware of the environmental issues, of the social issues, of difficulty situations of people. And what happened, I think, in the development of medicine through the last, let's say, 80 years or so, is technology came in. And of course, technology brought us many great things. And we are alive because of vaccines, and we are alive because of antibiotics, I'm quite sure. So, but in all these technologies, we stopped asking about the person. We thought that a diagnostic tool like a blood test tells us the whole picture. But only a patient can add to this picture to make it holistically. Because yes, you see a certain blood value, but you don't know, like your iron is low. Yeah. If there is a woman in front of you, you might ask her, or you should ask her, how much are you bleeding during your menstruation? Because I just fighting an iron deficiency then with some tablets or even a transfusion probably might not help on long term, because she's just losing a lot of blood every month. And this is what happened, I think, and this is still happening, because the better we get in technologies, if you think about genetics, about cancer diagnostics, the more we lose the person, and the more the medical training is focused on these technologies and on you know, a new disease here and a new treatment there, but losing the patient-centeredness. And I have to say, I sometimes criticize in many kind of meetings when health experts come together, and I'll sense in the room a kind of we and they.
Yeah.
And I often stand up then and said, guys, it's about us. It's our health system. You can be a patient in the next second when you have a heart attack in here. So what I really miss is people in all kinds of levels, you know, in the education of health professionals. And you're right, yes, in nursing, medical anthropology is more present than in medicine in some countries. And in the daily care, but also up to the politics. And what I miss, and this might be not only Austria specific, but as we both live here, there is no long-term strategy in healthcare. You know, every 4 to 5 years, when we get a new government, if it sticks to that rhythm, we get new health policies, and that's absolutely useless. Health needs long-term planning, long-term budget, and if we look at the current statistics of healthy life years, we are at the end of this line in Austria, and we look to the Scandinavian countries and say, oh yeah, they have more healthy life years. Yeah, because they invest in prevention.
Yeah.
And they invest in health promotion. And to invest successfully, you know, this is where a medical anthropologist come in. Because one thing is, yeah, you may design, and the big thing now is co-creation. And I think it's really time that this is lived in politics as well. That not only some people in a nice office in the health ministry design a new plan for let's promote XY, if you don't look and don't talk to the people and develop with them. And the medical anthropologist is the expert to work with people. And being, I sometimes say we are the bridge, or we are bridging, or we are translating, or we are connecting, because we have the big picture, we understand the politics, we understand the medical issues, but we are also expert in listening to the people and trying to help design plans. For an example, I work in occupational therapy training for some years already here. And occupational therapists are mainly white women, white Austrian women. And that's nice, but we need more diversity in this health workforce. Because imagine you have an elderly immigrant man who is not white and who had a stroke. And then the scheme is taken, what would an elderly Austrian man would do to get healthy again? But this probably immigrant man comes from a region where they have a totally different understanding of medicine. And a very good example. I have a friend who is Syrian, and he was a physiotherapist in Syria. And he's not very sporty. And if you know physiotherapists in Austria, they're very sporty.
Very sporty.
And we were discussing about how he, working at the university hospital in Damascus, how he was exercising physiotherapy. And he said, yeah, I had 1 hour with the patient per day in the hospital. And I was coming and I was doing something with him. But the Syrian concept of physiotherapy is not that you give a bunch of exams and you teach them to the patient, and then you send the patient home or even in the hospital and say, I'll come back tomorrow, and you train, you exercise. This is not the Syrian concept. So no wonder when you have a Syrian person with back pain coming to an Austrian physiotherapist, which is also a very wide Austrian profession, with very few diversity in, and then the person is not getting better because the person is not doing the exercises. And this is, you need cultural sensitivity. You need an awareness of factors. You have a hardworking person, and you tell the person, oh, you have to do sports, you have to exercise more. If the person is really hardworking all day in construction, the person is tired, and then you tell a person to exercise more. It's not working if you don't look at the person, if you don't look at the holistic context, and you don't have, as a health professional, and this is why I love it so much, anthropology, I mean, the structural competency as well, the knowing how my system works, but what can be the topics that might be at strike when people come together who are not born in a country and who have a migration history, because then system clashes, and we are not writing handbooks of how our health system works, and we are also not writing patient histories which are holistic and picking up more than patient is 45, female, back pain.
We missed the entire story.
We're putting not even half the story in. That could help at the end, because we are saying today we are person-centered. But I often don't see any person-centeredness in this whole thing.
I would be the first person to agree with you because of my story. I think that it's very interesting to see the cultural differences. I thought about doing kind of a blog post or a story about my experiences in the rehabilitation hospital in Austria. It was so funny to see that I don't think that any of the physiotherapists were above 27-year-old. They're all white and Austrians, predominantly women, extremely fit, like dressed for the role. And most of the patients were actually with migrant background. And it's just so funny to see the huge gap between the medical side and the patient side, that there is no understanding. There is one person that tried to train people as if they're going to run a marathon, and the poor patients who come and just want to get better. And I think that eventually these little gaps are creating a giant tear in the patient journey. And for me, I'm kind of a devil advocate, because, every time I have a discussion with a healthcare executive or professional in Austria, they tell me the same thing, that we have almost a perfect healthcare system here and everything is shiny. And I tell them, you know what? You have good quality of care compared to a lot of countries in terms of, researchable, measurable outcomes. But just the gaps in the patient journey and the gaps in care are so huge because of how the system made that everything is basically private practices. Some of them work with the insurance, some of them don't. And you have to tell your story all over again every time. And you're totally dependent as far as I'm concerned, on bias, which I think is a huge topic in medical anthropology, right? Because the way you present yourself in these 5 to 10 to 15 maybe minutes can determine your outcome. Am I right in this?
Yeah, you are, because you need to have a high health literacy. You need to be very well educated, and it doesn't help only your personal education, but knowing how to navigate the system. And it's good to have more money than you need, as you said, the system is struggling. And I also disagree highly when people say the system is good, because as a medical anthropologist, as a person who speaks several languages, and as a person who likes to help others, I've had so many medical encounters as a translator, as an interpreter in Portuguese, for example, but also just going with friends to the doctors and being the advocate for them, and people not getting good care because of racism, because of discrimination, let's name it, and because not being taken seriously. And it makes me angry, because it would be basics, yeah? So I have this story, my friend, she was a Black Brazilian woman. She had allergic reactions. And a certain time of her life, we took her to an allergy test. And the allergy test gave some inconclusive results. So the skin test. And as her friend, I knew about her high blood pressure and her medications. And the doctor was not asking her what she takes or whatever. It was the dermatologist in these clinics, and was writing a prescription. And I looked at him and like, do you know that she has high blood pressure and she takes blah, blah, blah? And he looked at me very angry. And then he scratched off the paper and threw it away and wrote a new one. Yeah. At the end, she had no allergy at all. You know what had happened? Her tear in the eyes, she had some blockage. And she was tearing all the time, but not because of an allergy. And she needed just a good ophthalmologist. So this was this holistic thing that the dermatologist tried to find something. The result was inconclusive or something very simple, and tried to prescribe her medication, never needed.
This is, this story, because it's not life risky, we can smile about it. Mm-hmm. But how many people are losing their life because of these processes?
Yeah. And it's like women not being taken seriously for their period pains. Absolutely. Besides, we know that 10 to 20% of all women in menstruating age have endometriosis.
Yes.
So this is like discrimination against women, and it's not taking evidence into consideration, and therefore I can't say we have a good health system. I'm sorry. I've seen too much exclusion. I've seen my own parents being my mom received the treatment she never needed. Yeah. And when I alerted her, it's too late now, there are consequences will be for the rest of her life because of this treatment.
Oh, I heard it.
And so what is also missing is like interprofessional collaboration. Exactly. And you say that you always need to tell your story again. You need to keep your papers together, your records. There is so much fear about data protection, and we have good laws that we don't have this electronic health record working the way it could work. Yeah. And myself, I get angry because I have to carry these papers, and I have pictures of these papers on my phone that I can show the doctor, and then what they do, oh, please send it to me, I need to print it out. Yes.
I had a keynote recently, and I said that we have a helicopter drone flying on Mars, like this is real.
Yeah.
But we still carry a bunch of paper to the doctor, which is for me ridiculous. And it's not a question of technology. Technology is here. It's a question again of the adaptation and the fear and the bias of people. And I think that because medicine it's treated different than other things. If it was like retail, it was already been solved, and you had an app in your phone that would solve it. And it kind of leads me to the question of using AI, like, because I've just recently finished to write a book called The Algorithm Will See You Now, and basically what the book is about is that the mistrust patients have in the system leads them to use AI and to trust it more than the doctors, with good results and dangerous results. And I want to ask you, because the system is so lacking, do you think that AI has a place in enhancing the patient journey, or do you look at it as something that is risking the holisticness?
At the moment, I think it's dangerous. Because when people are we're talking about using large language models, right? Like
Yes.
the ones that are out there at the moment. And they are still inventing, and they're still people pleasing in their texts. And if you don't have the health literacy or even the literacy at all to be critical and look at the sources or even ask for sources, I think it's still dangerous. And we have already seen it happening. And on the other side, we need to acknowledge that people who are, for example, don't have enough money for a psychotherapy, they find now help, which is very questionable help, in those AI things, you know. I would say we have other opportunities because we already have online consultations, like also chats. There are projects about that. We have also what they call in Germany diggers, digital applications for help, for health and help, right? And there are some which are approved by a governmental body that show improvement in, for example, mental health, in better sleeping, in monitoring your chronic disease. I'm monitoring my migraines, for example, I started using an app monitoring my headaches and migraines, and it was enlightening. I did not even need to show this to any doctor because I could see a pattern. I could think of, okay, but because I have a high health literacy and because I have a lot of body awareness, and the system, I always tell medical students, you know, what you learn currently in the medical study in Austria is how to treat a white, middle-aged, well-educated man who has a quick fix problem. This man does not get a chronic disease. This man has something we can fix with either one medication, with either one surgery, with one treatment. But somebody that sneaks in the system, gets clear diagnostics, gets help, and leaves the system again. If we look at 51% of the Austrian population are female, the medical study already misses us. And if you look at how many people acquire chronic diseases or a handicap during lifetime, which is much higher than people born with any difficulty conditions, you know, we acquire them through lifetime. It's clear that medicine, how it is practiced at the moment, is not meeting people's needs. What makes me sad, angry, and being an advocate is we know already many things and we could treat people well, but we don't do it. For certain reasons. Some of these are personal, some of them are biases when a doctor treats somebody, but some of them are at structural level, at higher level. For example, that we have a huge lack of occupational therapists for kids. If you are in Tyrol, you have 8 therapists by the ÖGK, by the biggest national health insurance, that treat kids for free. 8 for the whole state. For the whole state.
Wow.
These 8 persons are doing the best they can, but their waiting lists are up to 1 year. And if you know how quick children develop, you know how much time you lose. And this is a structural issue. Why the hell don't they get more contracts? It's feeding a system where those who have money, that's nice. Okay, those who have money pay for the private therapists, and there are spaces for those people who don't have that money, but there's still too few. And we don't have like occupational therapy is not included in what you know as mother and parents passport. When you get a child, you get this document. I don't know any English name for this. And the occupational therapy is not in there because there was a political discussions and they didn't win the game. And we know that if an occupational therapist would early enough analyze a child, it would get help in a stage of the child's life where so many things could change. Many kids just pop up with problems when they go to the mandatory kindergarten year, when they're 5 years old, or when they go to school, and in a aware school teacher says to mom and dad or to any relative, like, something is wrong, or we need to look at this. We have lost many years in the child's life to get help. So this is structural. And I would love to have changed these structures because this is our kids. Those we should support in being healthy individuals who once will continue to construct this country and by the end of the time pay our pensions, right?
Yeah,
So
exactly.
This is, we know those things. And we know, for example, because you said about the health system before, there are enough international studies that show that Austria has very high barriers in the health system. It's very difficult to navigate. And I can say this, I am able to navigate it, but when my friends who are migrants need help, or when my sick father needs help, I need to sit down, I need to think through, I need to call contacts I have, or I need to look up something on the internet because it's so complicated. So countries with a very good primary healthcare system based on primary healthcare centers like the Alma Ata Charter in the 70s of the past century said, like, it's so high barriers. And I don't see many activities to destroy these barriers, to deconstruct them, and to reconstruct an easier system.
It's so interesting because medicine is progressing. Like, if we look at the data, medicine is progressing. But I think it's also regressing in the kind of the loss of community healthcare. We have primary care as a big topic, but when I grew up in Israel, first of all, until the age of 3, you had special baby centers that midwives and specialized nurses would make sure the development of those kids is right and do interventions, including occupational therapists, when needed. And then you are moved to a pediatrician, and the pediatrician is the child's GP, and they know the family. And then you're moving to a GP, and the Israeli system is also based on what we call in German Krankenkasse, or sick funds, or kind of a national coverage insurance. But the difference is that here in Austria, almost every doctor is not sitting in the offices of the insurance. They sit in their own private practice, and they get money from different insurances. And I think that because of the different system, the different bureaucracy, we created a situation in which the gaps are so big. And what I see in Israel, we have a lot of gaps too, but the IT system is much more optimized. And the fact that you have your medical record belonging to this insurance and to you, of course, even if there is another doctor that you have to see, they have the same access. And there is one kind of path, and everything is in the same system. And I think that the backbones of fixing it is, first of all, structural in terms of policy making, then educational, then IT. I think health IT is not sexy enough that startups try to disrupt it, or we don't talk about it enough. And eventually, we need to go back to those preventive and community services. And when you talked about occupational therapists, which for me is one of the more the least utilized or the most underutilized profession in healthcare, because they are trained as holistic thinkers. I want to talk about nurse practitioners as well, because
absolutely,
any study that I read, where you have this community approach, and nurses get more let's say powers. I will call it powers, and not because one procedure or more, one prescription is not describing it. When the standing of a nurse that is highly specialized and educated is higher, we see better health outcomes, right? And I want to ask you, is this just a political issue? Is this just the ego of the Doctors Association that are not allowing this to happen?
Yeah, partly I would say yes.
Yeah.
Probably some people might get angry, but as an anthropologist, I say yes. Because if you look about how has the nursing profession developed in Austria especially, from this assistant position, and nurses were not allowed to marry. If you go back 120 years, you could only be a nurse if you're not married, but you marry, you could not be a nurse anymore.
Wow.
So they had to stay in the big AKH, one of the biggest, oldest general hospitals in Europe. Nurses, they were sleeping in the rooms of the patients. There were these big hallways with 20, 50 beds, and they had to stay there. They were not caretaking. They were called Wächterin. They were called it's like controlling them,
Oh.
So this is where it came from, and all this development. And Florence Nightingale had a big picture. Florence Nightingale thought about care in a very different way, and there is this power of medical doctors that is unhealthy for all of us, I would say, because I also worked in nursing education, and I still work with nurses, and diabetes nurse and a nurse expert in diabetes knows much more than the average general practitioner about diabetes. Absolutely. And the diabetes nurse, as she's an expert, is on top with the current developments in wound care, in medication, in whatever, And I once had a call, I can talk about it, but because it's a long time ago, with somebody from the National Health Insurance Board about patient management programs or disease management programs. Yeah. Because they call it disease management programs, but they manage the patients. Of course. That's another interesting aspect. But what he said is just 1/3 of all diabetes patients is part of the management program because it's not mandatory. And if the doctor does not see the necessity of putting the patient in the program and then they get better care. We have tons of literature internationally how much better disease management programs are for chronically sick patients. They don't get the care. And the thing is also, it's not only putting the patient in there, but the doctor needs to take the moment, or a nurse which works at the primary healthcare center where they exist, to explain to the patient why it is good to be in such program. Because of course there is this feeling which we are trained also in Austria of liberty of decision and autonomy, and we have a very low health literacy in general. You need to explain why a disease management program is better instead of only going to your GP. But if you do this and you get this understand, and we also then need, of course, we need those diabetes nurses speaking foreign languages. We need them culturally competent. We need them with diversity competency. And we need them with structural competency. I did research in Brazil a long time ago, and there was this diabetes patient. And she was giving me an interview about something else. And in the middle of this interview, she said something, and I thought, yeah, but, I know you do it different. And what she was saying was she was cooking a lot of fresh fruits and vegetables and healthy meals. And I knew what was in her pants, and this was not healthy at all. By the end of the interview, she said, yeah, it's so expensive to buy healthy food, and I don't have the finance resources. And so we need those professionals also structurally competent to be aware of financial situation of people and ask the people, Our structural competency training developed by anthropologists ask in a tool for also the financial situation, because the financial situations determines a lot And our system is not for free. Yeah, people have the feeling the health system here is for free, but it is not for free. We are all paying for it, and if you are not able to pay extra for it, then you're getting less healthy. You don't get your health back, or you don't get good care, or like say the standard that is paid by the insurance might not be the best standard for you in this moment.
Yeah. So we're talking like a lot about health literacy, about system navigation, which I personally think that AI can do it in the background, and case managers, which is a huge topic, should be involved. I'm actually radical. Yeah, I'm a health rebel. I think that doctors should not lead the care. I think doctors should make clinical decisions, and nurses should be the care managers of the patient. I'm not talking about also admission. People say, yeah, of course, some outpatient cases, like we talked about, diabetic nurses is also very successful in Israel, where I had a lot of expertise in the system. I think that in the community primary care, I would be so much happier if I get a phone call from my nurse case manager, and you can argue that the case manager may be medical anthropologist, and I would like you to argue this, and that somebody is making sure that I'm on track, because I manage, if I'm not mistaken, 8 different chronic diagnoses. We can talk about the how we label disease in another call, and is it really 8 different diagnoses or not? But there is no case management. I'm the case manager of myself. Now my mom is struggling with cancer, I'm afraid, in Israel, and we are 3 family members who had to be the case managers, because this is the reality of chronic illness or chronic acute illness. So I want to kind of ask you, who do you think is the best case manager in this case?
If I think about the competences of nurses, I would say a nurse. I would like to have in each primary healthcare center nurse practitioners, people with case management education, people with community health education. And I would like to have a medical anthropologist there just supporting the system, because what I've learned in Brazil, what they do in some medical schools, is from the beginning on, when they start with the students in the first day, they go to the community outside. Wow. I went with them, because I also teach in Brazil. We went outside with them in the community, and they went from household to household. Of course, this needs openness, that people open their doors, and Brazilians do this. In Austria, you probably need a different system, but they got to know their community. Who are they serving later, and what are the local health issues?
Incredible.
And this depends on where you live. There is a difference if you have a medical school in a rural area, or if you have one in a huge city like Vienna. And so what a medical anthropologist could help in a primary healthcare center is to know the community, and to be out there also in the community health centers, in the parents' kids health center. They exist in Vienna, In Austria, we have these parents' child centers, but there is no recommendation, please go there, or there is no mandatory thing, please go there, get frequent evaluations, you get help. This is just people who go there who know it, and people who feel welcome there. And as you said before, the medical professionals are not reflecting the diversity of the community of the whole country, And so I see it with nurses with a specialized training. I don't see it with a nurse who has just graduated, but with a nurse who has experience in practice, who then had further training. Community health nurses are a fantastic resource. I had this experience with my father last year. She was not officially named a community health resource, but because it doesn't exist in this district, but somebody came who is a nurse and who knows about the care system if you need it. And I did the same. I'm the case manager of my dad. I gave her the introductions on the phone. I told her, look, my mom is hearing difficulty. Please be aware how you speak, and don't wonder about strange questions, because then she doesn't hear it, doesn't ask, can you repeat? And giving her a picture about our family, where she's going into. And it was a great appointment. I wasn't there, but it was a great appointment for both of them. But we only got it because I managed it. At the hospital, when he was discharged, the discharge nurse did not offer any information on that, and did not even ask if they would need help. The only thing what they did was instructing my sister how to treat the wound.
Yes,
which
is not always the case. Sometimes you just get, like, I've seen it in the US, you get a leaflet, like a little page with some instruction, wash this, don't shower this, and so on. Which is also driving me crazy. I think that the fact that we are underutilizing professionals like this. I'm teaching in a master degree here in Austria, in Krems, where it's a health science degree. So a lot of time you're being compensated for doing a master degree in your career, right? But we're not always seeing the opportunity that if they're compensated, we can really teach them something that helps them, right? We can train them to be nurse practitioners, or we can train them to be better professionals. And for my, not even surprise, amazement, when I'm teaching a course that is supposed to be about patient advocacy. That's my mandate. But I only teach like half an hour of patient advocacy. Because what I do, I teach them human advocacy, and I ask them how they feel. And in the end of each of these sessions, it's always like a concentrated seminar for 2 days. Half of the class is crying. And the reason is nobody ever asked them how they feel. They all tell me the same thing, that they were trained to not think holistically, but rather to distance themselves emotionally from the patients, and to think in an only systematic way, due to a lot of reasons. And their resilience and their empathy is being damaged, which leads to worsening of the care. So we have also not only the health IT and the literacy and the systemic failures, we have training that is leading, and training and practice that is leading healthcare professionals to leave. I think that sometimes I just wake up in the middle of the night and say like people don't understand what will happen if we run out of nurses. And the numbers are staggering.
Can I jump in quickly?
Always.
So what I've learned since the last 20 years, I travel back and forth to Brazil. In Brazil, nursing education takes 5 years. These 5 years, these graduate nurses are experts, and then they can do a master's and a PhD, but it takes 5 years. And in Austria, having put all these things with the academic thing, that was very good, having academically trained nursing, but putting all in 3 years is too much. Why does it need to be like the Bologna process of 3 years if it doesn't match our needs?
It's 4 years in Israel and in other countries. And people think, but why do they need to spend time in classroom? But they don't understand that they spend most of the time in hospitals, actually, already in training, right?
No, nurse education does not need to be a 3 years bachelor.
Also, midwife.
4 years is much better already. 5 years is, I tell you, Brazilian nurses are amazingly trained. What they missed, but this is Brazil, of course, is cultural sensitivity training, because it's a huge country, but it's perceived as culturally that there's nothing about migration in there, for example. But this has also historical aspects and structural things. But in Brazilian nurses are really highly trained, and of course they have then their community health nurses out there, and they really know the community. I've visited several primary healthcare centers, and those nurses are, they know what's going on, and this is what is needed, and actually already needed before, as a preventive measure.
Absolutely.
That people have a community center where they go to for information, for leisure, for picking up something. I don't know. Instead of you want a vaccine, you have to go to your GP. Why don't we have a community health center? Why, when somebody comes in and gets a vaccine for himself or the child or whoever, gets other informations, and gets to know people. It's against loneliness. There is numbers about so much loneliness here, and in many countries in the Western world. And this would be measures that would benefit, in a much broader sense than just, I need a vaccine, I want one, I go to the doctors. There's no need to have a doctor giving you a vaccine. There is nurses who can do that. And
it's part of this consumerism in healthcare. Do you know, I lived in China for a few years, and there is a beautiful thing. You have almost in every, neighborhood, a little community center, but it's not a building that you need to climb the elevator or so. It's like a shop. It's an open, like a cafe. There are tables. People are playing chess or mahjong in China and so on. And there is a nurse there, a community nurse. And instead of waiting in the line, queuing in the line for the GP because they're so lonely and they want to talk to somebody, they have the social aspect. They have sugar, blood pressure, and other vitals being monitored every day, vaccination and public health and prevention. And this is such a simple, beautiful way to promote health, but we're not doing it. And the thing that drove me the most crazy was that in some countries, including my home country of Israel, they decided to take the school nurses out of school.
No.
Which is really horrible. I think it should start in kindergarten. I think that I proposed to the health ministry, which of course I was a student, so they kind of laughed at me. I proposed that we design a new profession that is a health educator, that is actually have medical training also, something equivalent of a field medic or something like this. But they are not only educating about health, they're also monitoring the preventing measures, because they didn't want nurses anywhere near the school. So I thought maybe we can put the teachers in the back door. And this is how I specialized in health education in my bachelor. But I think eventually all the beautiful things we're talking about cannot happen if politicians are not allowed to happen. Because if we take a nurse and open a shop and put a nurse there, what is the legal kind of mandate that she has to do what she's doing? And this is a problem.
Germany has some projects. They call it health kiosk. I don't know much about it, but there is some project also to bring health back to the community. What is interesting, this is just a little fun fact. If you look at studies, we know a lot about people who are poor, who are vulnerable. But if you look out at the numbers, we don't know much about higher upper middle class and upper class people who have a lot of money. I think this is really interesting side aspect, because a community very often is mixed, and everybody could benefit from it. And it doesn't mean that somebody, just because you're rich, you're not lonely at home in your whole big house, and you are an elderly lady and you get your services, but you're lonely. So I think community in Austria needs to be rethought. And I think an anthropologist here and there, structurally placed in health organizations, in community, can help to understand, can help to navigate. What we really know well is how to enter in contact with people, how to talk to somebody, how to make people talk to us. And you said something about nurses. So I teach in nursing education since 15 years. And around 2017, I started noticing that nurses randomly, wherever I met them, not only my students, but in private, and whenever I asked, how are you? Or some conversation came up, they started talking about violent incidents.
Yeah.
And for 2 years, I was like, something is going on. And then I started a research project in 2019. We got a partner, a local hospital, not in the state of Vienna, in another federal state. And unfortunately, it was stopped by the pandemic of the coronavirus, but our results were very clear. what is happening. And it made me very sad and angry, but I also could see the structures. Yeah. And what we could see, for example, was a huge gap in between generations. So why nurses in their late 40s and upwards were just trained, oh, you have to stand this or leave.
Yes.
The younger generation says, no, I don't want to stand this. The employer has a duty, which is in our law. There is a worker protection law that says you have to protect your workers against violence, and it's not carried out. What I found out, I think this is also interesting to the health system, and it's very specifically Austrian, because we're not good in data collection, right?
Yeah.
And we're not good in using data. Sometimes we collect a lot of data, but we're not using them.
Yeah.
So what hospital has is critical incidents reporting system.
Yeah.
CIRS. In that specific hospital, it was the case that you could report a violent incident against yourself, but only you could report it. And only the guys and ladies from the security had the mandate. They had to document when something happened.
Yeah.
What happened in the daily routine of the hospital? A violent incident happened. The chief nurse comes in, and the nurse who suffered the incident tells the chief nurse. This is like getting rid of the emotions, and this is healthy, yeah? Getting things out of you. Yeah. And then the nurse continued to work. The chief nurse heard all the stories, but she was not allowed to document. What gets in the end is that the hospital leaders don't see numbers. So many incidents happens because nobody's allowed to document, and the person feels the relief after talking about it, has no time, and the chief nurse is not allowed. So we recommended them, please change the system, make it possible that the chief nurse from the wards, she was leading 2 wards, could make these entrances that you have a quantity notifies. Yeah. And what they also did was they changed in the system to have certain buttons. What do you need now from us? So this is just reporting, and if some sexual violence happened, for example, the system behind alerted, and there was always a need to address somebody behind, and the occupational psychologist or occupational medical doctor to call out the person, how are you? And I think this is a huge change, because there is a difference in between telling somebody, feeling okay again, but reporting it to get numbers, because only numbers work to convince hospital managers to change things.
Absolutely. And interesting what you said about sexual violence, because sometimes it's a different method, and in many cases, in many countries, not even collected due to privacy. So we don't know the scale. I must say that I'll be the devil's advocate again, because that's usually my role. We have a tendency to demonize patients when it comes to hospital violence. And there was a committee in Israel that did some research, and eventually the results were very damning for patients. It was kind of, we healthcare, again, we against you. And nobody talked about the systemic causes. Like, I totally understand why a normal, not talking about a violent person, I can understand a normal person to get enraged so much because their family member is being poorly treated or gaslighted, that there is a friction. I'm not justifying, of course, violence, but I've, with my own grandmother, that she was dying alone in a room in a hospital from sepsis, undiagnosed, and she didn't even get morphine or any support just because somebody in the ward was too busy to do it. It was much more complicated than this. She didn't even get the basic care. And I tried to give it to her as a medical professional, and I was blocked from doing it. And then I realized what's happening now, that we are people with emotions, and we are in the most vulnerable state of our lives with ourselves or with our loved one. And we feel the system is against us. And I don't see a lot of efforts in many countries to prevent this friction by designing better patient journeys. This is something that drives me really, really insane.
Yeah, and patient journeys, and including better hospitals, Going back to the example I gave you, we did observations in the waiting area of the emergency room. I tell you, I would get angry in there waiting for 5 hours. Wooden benches, just wooden benches. One toilet for 100 people. The coffee machine was outside. No system of calling, so everybody afraid to go to the toilet or to pick up coffee because you could get called. I wrote a whole nice report, and I did research for them, gave them recommendations. There is, of course, lovely furniture and how you could do better. But when I walked in this emergency room the first time, I was like, no wonder that you get aggressive in here. And you know, why do we do this? It's always like, why don't we think starting by ourselves? When you plan something, what I would need or how would feel that to me, why don't we change that? And why don't we involve people? And there are so many experts out there. And the patient journey, as you said, a patient who is waiting 6 hours in an emergency room needs a toilet, needs water, probably needs a coffee, needs food, needs a break in the fresh air, whatever, you know. And there are systems out there. And it's not like, it's how we want to treat each other. And I always try to think first the perspective of the meta level of the system and the structure. This is my anthropological view, you know, because people navigate systems. Of course, people also frame systems, and people influence systems, and people design systems. And systems are always designed in a way of, it's always about power relations. I have to cite Michel Foucault, I'm sorry. I always have to cite Michel Foucault, reading the history of hospital, the birth of the clinics, the name in English, the Geburt der Klinik, and it's enlightening. Yes, it's France in the 60s, but it's enlightening. And if you read this as a health professional, you understand why clinics are still work like that, when they are still working in the traditional way. I also have to give a very good different example at this call, because I grew up in the countryside, but in a little skiing town. So there is the GP practice were two brothers who inherited this from their father. And the two brothers, they always had a laboratory, because it's in the countryside, in the mountains, in the Alps. They always had nurses working there. And because of ski tourists bring a lot of nice money if you care for the ski accidents, they constructed a private clinic. But what happened, because of these clinics, they had a radiology machine, they bought a CT scanner, and they employed other medical doctors. And we, the general population, benefited hugely from this. I have always taken my blood by nurses. I always got my transfusions by nurses, even in the forbidden time in Austria when they were not allowed, because that clinic was just working. And as a child, I always had the feeling they are all working together. Of course, there were these two doctors which one I liked more than the other, and I went to the one, but the nurses were super important there for me always, and I always learned nurses are so important. So when I started working with nurses, I had to learn, like, oh yeah, others don't see you important, but you were very important in my life because I was a lot sick in my child's life. But I always seen that, you know, so it's possible. And they did it within their scope, and they sharing their practice was super, because one of them always had a free day off. And everybody in the region knew, if you want Dr. X, his day off is Tuesday, so he won't be there, so don't go there. And if you want Dr. Y, he's not there on Wednesday, so don't go there. So it was always, it's possible, you know. And now they have a physiotherapist, you know, they have involved other professionals, and it was so important to have this example, because it's in the countryside and we didn't have access to specialists. But with them, there was an orthopedic surgeon coming once a week. There was an internal clinician coming once a week.
Perfect.
You know, it was growing, and now his daughter is leading, and she has employed other doctors, and another, she has another colleague, and they are still leading it in this way, yeah. So
Beautiful.
it's possible, and I never saw it as a possibility for me getting a doctor or a nurse. This was never an idea, but I always saw them working together. And I didn't see what you see in other Austrian hospitals about power relations. I did never see a doctor telling off a nurse. I did never see somebody told, "Oh, you're not qualified enough. I have to do this." No, it was like, yeah. And I think this experience, people need to make such experience. We need to visit other places where it's working differently. We need to do internships. I did this as an medical anthropologist, but we need to allow this, because only if we see interprofessional collaboration working well, we can imagine this for us. Because in our system currently, we have not seen interprofessional collaboration working well. If we have seen it all, we have seen the doctors up and all others down. And if it's not happening, it's not happening. But it's something, I think, if I would have any influence in curricular design, which I don't, but if I would have, I would take, and it's different institutions, of course, in Austria. Yeah, in other countries this might be easier because it's not different institutions. But here it's about universities of applied sciences and the medical university, and even the University of Vienna, because pharmacy is at the University of Vienna, and pharmacists deal with patients. So I would do interprofessional collaboration courses from start on, because I'm tired of explaining medical doctors what an occupational therapist does.
Yes.
And that's it, you know. And that's often my role as an anthropologist, being the bridge and trying to help. And don't you, even as a case manager of my dad, don't want you refer my dad to, because why don't you need to mention that even?
Exactly. They should. It should not be that the doctor is the center of care. The patient is the center of care. A doctor is one of the experts, and a doctor is not a physiotherapist, is not an occupational therapist, is not a pharmacist. And if they were trained together and learned the humbleness of bringing in other expertise, we had more fertilization and better care outcomes. And regarding to what you said, I think it's working beautifully in those urgent medical centers, like the small ones, or community health center, primary care, because people don't know it. People think that as large as the hospital is, like we have in Vienna, the AKH, it's if you look from the air, when I fly over Vienna to land, you know, this is the biggest building you can see, right? And when I did my master degree in health management, one of my professors said that he called it healthcare warehouses, this huge healthcare mall, these huge hospitals. They're far worse than small hospitals. And he brought numbers from the UK. When you have smaller hospitals, sometimes specialized hospitals, you have better care. And I think that if we kind of try to connect everything together, we're again talking about community, we're talking about collaboration, we're talking about holistic view, we're talking about having people such as yourself, which are experts in holistic views, not only in academic stance, but in decision making, in the actual practices. As advisor, you know, I worked a lot to promote chief patients officers and patients in residence. It would have been amazing to have residencies of medical anthropologists going places. And I think that it shouldn't be siloed. It shouldn't be like an alien profession. And we should never have these echo chambers that we have these conferences when experts are rubbing against each other, their successes, instead of just talking about things. And yet again, this month, I will attend a conference in which it's supposed to be about the patients, but there is only one or if I'm not mistaken, 2 patients who are speaking and 30 others,
Mhm.
medical professionals who are speaking.
And I
Uh,
understand that not all patients want to go on stage, but
Absolutely.
anthropologists, medical anthropologists can
Exactly.
be a voice. And if
Exactly.
there is a medical anthropologist in Vienna, she works about rare diseases
Yeah.
and people with a certain rare blood disease. And people who have these specific blood disease are immigrants in Austria, first or second generation, and
Yeah.
they are Black people.
Yeah.
People of color, so they're very much discriminated and
You
suffering.
talk about sickle cell anemia?
I do.
Okay.
Cell and thalassemia. And she is turning into an advocate. And she is sometimes building the bridge of that people get better care and that people get heard. And she goes to conferences and tell their experiences because the people don't want to be on stage, or they are single moms. They, of course, they have to work. They don't have the time. And patients often, as you know, they don't get paid to go to a conference.
Of course.
And people would need to get paid for that. So one possibility is there is an anthropologist. She works with them. She is their voice out there. And
Wow.
I would say this is a possibility that we could think of if you think of involving medical anthropologists to be the voice of a certain group of people, because we could collect their voices. Of course, we cannot be. I don't have the physical experience of having thalassemia, and I think my life for it, but I can tell how people feel and what they experience, and I can take their needs to the audience, and I can take their wishes, and I can take questions back or development. And this is an opportunity where, yeah.
It's very rarely that, like, I always get new perspective in the conversations like this, but it's very rarely that I kind of come out with a conclusion.
Mhm.
And I really think that I always struggle because people ask me, yeah, but how do we take somebody who is a caregiver or a patient? It's a very, very, very low percentage who wants to be out there and be advocates or be bringing the voices into decision making to be kind of a chief patient officer.
Yeah.
So first of all, I want to graduate it into chief human experience officer,
Mhm.
or we can call it in another name, but maybe we found a solution. Maybe we don't need to invent the wheel with new trainings, which is something I really thought about a lot. Maybe medical anthropologists have the training to understand the feeling, needs, and wants of
Mhm.
population that needs them and can represent both sides, because eventually, if we will have in medical organization and hospitals and so on chief human experience officers, they can take care of both sides. They can take care of violence incidents. They can take care of the well-being of the patient journeys, of the professional development. And maybe, and this is, I think, will be kind of the end of this part. I definitely want to do another part with you because it was absolutely fascinating. Maybe medical anthropologists should be the ones who are those chief human experience officer, or maybe if you have a better name for me, uh, we would love to
That's a good
develop it.
question. Not for now, but I will think of it, and next time I'll come up with an idea. Yeah, I like your idea. It's a possibility. But what I have to say, we then also need training for it, because coming out of academia, you're not well trained enough to work in the health field. I had to train myself. I had to look for trainings. We also need to see that academia is not preparing people for real life world problems sometimes.
Absolutely, but it's interesting. I think from what because I'm teaching and I'm talking to a lot of medical professionals and patients. From what I'm hearing from you, and it's not the first conversation we're having. Of course, this one is recorded, but we had a lot of offline conversation. I really think that the academic basis that is needed, probably medical anthropologists have the best starting points from all professions to graduate into being in those roles. Maybe it should be a different, extra certification. Maybe it should be a master degree. I don't know the answer for that, but I think that medical anthropologists are absolutely crucial to the system. It's like when nurses are the backbone of healthcare. I think that you guys or girls or women or men or experts, because this is something that is for now, you look at this and you say, oh, this is a professor and they write books or articles. medical anthropologists are needed in healthcare as much as any other expert is needed in healthcare. And I think it's a real medical profession, which is not always being referred to, right? It's referred to an academic profession. So this is kind of my conclusion from our wonderful conversation. And do you want to add anything to this beautiful ending of the call?
Oh no, this was a beautiful ending, and I think I'll take this out in the world now and think of it and talk to my colleagues, and brings me, of course, up to new ideas, new job opportunities for people who want to have such roles. And I continue to lobby for my field because it's a passion, and I love medical anthropology, and I'm looking forward to any other conversation we have offline and online with you. Thank you very much for the invitation.
Thank you so much, Dr. Jaeger, for accepting my invitation to come here. And maybe we should write an article or have some sort of output that can kind of help to bring more medical anthropologists into the field that we're talking about. Thank you so much, Margret, for being here. It really was insightful. We will probably do another part, digging deeper into some of the topics. And I really hope that we will collaborate more. And I will link in the description of this episode a link about you, of your choice, that people can learn more about your job or medical anthropology in general. And for my lovely listeners, thank you so much. I think it was one of the longest episodes that we had. It was not scripted. It was just a naturally flowing, wonderful conversation. I need to reflect on it. It's really been a very, very insightful for me. Thank you for being here, and I'll see you next week. Thank you, Dr. Jaeger.
Bye.
Bye-bye.